Well, good morning, everyone. My name is Albert Whitaker, and I am the Director for Community Impact with the American Heart Association. This is a very vital time to have a conversation around maternal health and hypertension. And so we want to begin by a welcome from Dr. Bridget McCabe, who is the Senior Medical Director with Blue Cross Blue Shield Rhode Island. Dr. McCabe is a dual certified physician in pediatrics and clinical informatics with fellowship training in health service research and quality improvement. She earned her medical doctorate with distinction in neuroscience and holds a master's of public health, both from Harvard University. And before joining Blue Cross Blue Shield Rhode Island, Dr. McCabe served as Vice President of Enterprise Clinical Quality, Data Science, and Informatics at Teladoc Health, which is, and additionally, she served as Medical Director for the Institute of Patient Safety and Quality of Virtual Care, the first patient safety organization focused on improving healthcare quality in virtual meetings, in virtual settings, where she spearheaded patient safety initiatives. Dr. McCabe is currently overseeing the public health operations and health efforts at the Blue Cross Blue Shield Rhode Island. So welcome, Dr. McCabe, and I'm going to turn it over to you.
Good morning. Welcome, everybody. I get the incredible job of representing Blue Cross Blue Shield this morning, and very excited that our organization is helping to sponsor this important discussion on maternal health and hypertension in the community, and very much appreciative of our long-standing partnership with the American Heart Association. It's been amazing that over 100 years, the American Heart Association has been supporting families and communities, and Blue Cross Blue Shield of Rhode Island in particular has supported these efforts for over a quarter of a century in Rhode Island, and really sharing that vision of advancing health and hope. And we look forward to everyone's discussions on the panels. We've got incredible local experts, and hypertensive disorders of pregnancy are one of the main causes of pregnancy-related maternal and fetal complications worldwide. And it becomes even more important now to underscore access to quality pregnancy and childbirth care. And we continue to find, even knowing this for many, many years, significant disparities in maternal health. And it's crucial for us to work together even more so now to eliminate these issues and support our communities. Here at Blue Cross Blue Shield of Rhode Island, it's a very important initiative for us in terms of maternal health initiatives and part of our overall health equity strategy. And we really look forward to working with the experts this morning to focus on pregnancy-related hypertension, explore ways to improve women's health. And as a pediatrician, healthy women, healthy babies. So turn it back over to you to introduce our incredible panel today. Thank you so much.
Thank you, Dr. McCabe. So I have the pleasure of introducing our distinguished panel. And so I'm going to begin with Dr. Lisa Domogowski. She's a clinical assistant professor of obstetrics and gynecology at the Warren Albert Medical School at Brown. And she's a member of Partners in OBGYN, a division of Southern New England Healthcare for Women. Dr. Domogowski completed her residency training at Women and Infants Hospital here in Providence, and she has remained at Women and Infants as a faculty member since 1995. And during that time, she has served multiple leadership roles for resident education among community faculty. And in her position as Associate Program Director, she continues the important role of engaging community faculty in resident education. So welcome, Dr. Domogowski. Next, we have Dr. Martha Cole-White, who is an assistant professor in the Department of Obstetrics and Gynecology and a member of the Division of Maternal Fetal Medicine. She attended medical school at the University of Pennsylvania and completed her residency and fellowship training at Brown. Her overall clinical and research interests encompass improving access to safe and equitable postpartum care and decreasing maternal morbidity and mortality. And she is the director of the Maternal Fetal Medicine Postpartum Clinic and co-chair of the Rhode Island Pregnancy and Postpartum Death Review Committee. Welcome, Dr. Cole White. Next, we have Dr. Libertad Flores, who was born and raised in Detroit, Michigan, to Mexican parents and the fortunate childhood recipient of safety net healthcare. She earned her undergraduate degree from Cornell University in Spanish, after which she worked in healthcare market research while completing a master's of public health in health policy and management from Columbia University. Dr. Flores is a 2023 graduate of the Rhode Island Foundation Equity Leadership Initiative, a 2024 Brown University Advocate for Social Change and Equity Fellow, and a past commissioner of the Rhode Island Department of Health, the Rhode Island Department of Health Commission on Health Access and Equity, better known as the CHE. She has authored and presented her work on patient experience and disparities in healthcare. And Dr. Flores is an alumna and clinical assistant professor of obstetrics and gynecology at Alpert Medical School at Brown University, and also practices at Providence Community Health Centers and Women Infants Hospital of Rhode Island. Welcome, Dr. Flores. Next, we have Dr. Elise Hausberg. And Dr. Elise Hausberg is assistant professor of maternal fetal medicine in the Department of Obstetrics Gynecology at Brown University and Women and Infants Hospital. And she completed her undergraduate degree in biology at the University of Pennsylvania, then attended medical school at Yale. She completed her OBGYN residency at Brown University and Women and Infants Hospital and her MFM fellowship at McGee Women's Hospital of the University of Pittsburgh. Her research focuses on mechanisms leading to cardiovascular disease after hypertensive disorders of pregnancy and development of innovative and community-partnered postpartum interventions to improve short and long-term maternal cardiovascular health. Welcome, Dr. Hausberg. So as you can see from the description of these bios, we have a very impressive group of panelists that are going to really delve in to maternal health. And so I just want to begin the questionings. I'm going to open it up with Dr. Cole White. And let's talk a little bit about what impact does diabetes in pregnancy have on long-term outcomes for women?
Thank you, Albert. Thanks everyone for being here today. I think one of the things that we wanted to discuss is how pregnancy is a window to future health and really how pregnancy can affect lifelong cardiovascular health. And so one of the things that we think about is diabetes. And the diagnosis of gestational diabetes is not only important for the pregnancy and for management of the mom and the baby during the pregnancy, but when we also think about lifelong health, specifically about cardiovascular health. And so for people who are diagnosed with gestational diabetes, which is about 10% of pregnancy, these people have over a 2 times risk of developing type 2 diabetes later in life, and they have a double risk of developing heart disease and stroke. And that's often something that's not thought about or talked about. And so it's really important to know that if your loved one, yourself, your patients, people in your community are diagnosed with gestational diabetes, they really need long-term care and follow-up to reduce their risks of cardiovascular disease later in life. And so that's important in both follow-up glucose screening to diagnose and recognize type 2 diabetes, but also monitoring blood pressure and cholesterol to help reduce people's lifetime risks of complications of heart disease.
And as a follow-up question, I just wanted to hone in a little bit on the Rhode Island Pregnancy and Postpartum Death Review Committee, and and what have we learned that could help support families in Rhode Island, from this report.
Yeah, so one of my other roles is serving as the co-chair for Rhode Island's Pregnancy and Postpartum Death Review Committee. And that's kind of changing sort of our focus a little bit. But when we think about people who are pregnant and postpartum in our state, and if we're really thinking about things that are causing mothers to die during pregnancy and postpartum, really in our state, it's not so much medical complications from birth as it is other complications in the postpartum period that include things such as substance use disorders, violence against women, and self harm. And so, really, is thinking about people in the community health space and taking care of people in the postpartum period, we really need to think about ways that we can reduce morbidity and mortality in our state. And that's really thinking about expanding access to things like trauma informed care, incorporating and integrating behavioral health services both into the antenatal, that means like while you're pregnant, and postpartum time periods, making sure that everyone who interacts with families is screening for domestic violence in a way that can help families speak up and get the resources that they need. As a state, we also really need to be thinking about extending access to postpartum support to people that will help with identifying conditions that can reduce the risk of cardiovascular disease later in life, but it will also help identifying people who may need extra resources in terms of substance use disorder, housing stability, safety from violence, and getting the care
Mhm.
that they need really in the postpartum period. And then, really, a big sort of shout out, I think, from all of us, really to listen to birthing people and to families and to listen to the struggles that they're having and the symptoms that they might be having postpartum, and really trying to get them into the appropriate care.
So I'm going to shift this to Dr. Husberg and really ask a little bit about what impact does hypertension in pregnancy have on long-term outcomes for women?
Thanks so much, Albert, for the question. And just to kind of echo what Dr. Cole-White was describing about the relationship of diabetes and pregnancy, we know that there's a very similar kind of thing that we see during pregnancy for people that have high blood pressure. And we can kind of think about pregnancy as sort of a cardiac stress test, right? We know that by the end point of a pregnancy, there are kind of massive adaptations that have to happen between the heart and the kind of vascular system to accommodate, sometimes an 8, 9 pound baby, a placenta, kind of all those changes that happen. And for people that develop complications during pregnancy, specifically high blood pressure, and we think about that kind of on a spectrum, right? There's something like gestational hypertension, where people have kind of just high blood pressure alone in pregnancy, all the way up to the kind of more extreme of preeclampsia or eclampsia, where they may actually have high blood pressure in addition to other organ systems being affected. Um, and for people who develop that during pregnancy, we know that, I think historically the teaching was always sort of like, we deliver you and you're cured, right? But what we're actually finding is that a lot of the morbidity and a lot of the complications that happen related to high blood pressure in pregnancy actually happen in the postpartum period. And, we've been really lucky over the last 5 to 10 years that we've actually been able to incorporate a lot more home blood pressure monitoring into our care of this population. And what we found is when we stop asking people to come into the office when they have a newborn and just had medical complications or have a baby in the NICU, but when we actually give them a blood pressure cuff and have them take their blood pressure at home, we're actually much more able to kind of identify and treat that high blood pressure in the immediate postpartum period. We have a fantastic program here at Women and Infants that's run by Danielle Simmons, who I think is actually on this call, which is our hypertension equity program, where we actually give people a blood pressure cuff. We manage their high blood pressure during that postpartum period. And what we've shown when we look at these programs kind of across the board is we reduce complications, we definitely lower the rates of hospital readmission. And what we're starting to see is that there may actually be an impact on longer term blood pressure. And that's really important because, just as Dr. Cole-White was talking about with diabetes, we know that high blood pressure in pregnancy is linked to a higher risk of long-term development of chronic hypertension and other cardiovascular diseases. And what we see is that, probably like before kids turn 5, so like within the first 3 to 5 years after pregnancy, about 40% of people that had high blood pressure in pregnancy will have developed chronic hypertension, basically. And those rates are even higher for people that have it in multiple pregnancies, for people that have kind of more severe forms of the disease. And so, just like I was saying before, we really can think about pregnancy as kind of a cardiac stress test, and such that for those people that develop high blood pressure in pregnancy, there's obviously a lot that needs to happen in the immediate postpartum period, making sure we keep people safe, that we reduce those morbidities. But then beyond that, it's really important that we start thinking about how we can actually improve those long-term outcomes.
So, Dr. Flores, I'm going to switch this around a little bit. There has been some talk here around referred to social determinants of health, and so for Dr. Flores, I want to ask what resources are available for patients facing systemic barriers. For example, no provider, not previously engaged in the healthcare system, lack of insurance, so barriers such as that, what resources are available?
So I want to apologize right now because in honor of Mother's Day, all of my children are acting up, including the pets. So apologies. But yeah, this is one of my favorite things to talk about. I work for a federally qualified health center, and actually Drs. Hausberg and Cole-White are also at Women and Infants. And so all of us have a commitment to seeing folks regardless of ability to pay or insurance, because we have the support of staff that help us get folks enrolled who previously weren't engaged. One thing that perhaps everyone on this call is aware of, but is a real blessing that is not afforded to everyone everywhere in the country, is that when you are pregnant in this state, you are guaranteed to have insurance. As a result of advocacy from many of the folks on this call, that postpartum coverage is extended from 6 weeks, not too many years ago, to now a full year postpartum. And so we know that some of these postpartum complications will appear within the first 6 weeks and some don't. For instance, especially mental health, substance use disorder, those can really occur during that first stressful year of life. And so now we have insurance coverage to cover the entire year postpartum. For folks that are not pregnant or recently pregnant, anybody, regardless of ability to pay, is able to walk up to any federally qualified health center in the state and seek care. It is true that we are in a crisis of primary care and in physicians in general and providers in general in the state of Rhode Island, but that is really an excellent opportunity to advocate with your lawmakers to increase the visibility of the advantages of working in Rhode Island, as all of the doctors on this call can attest. So you can walk into any federally qualified health center and ask for a primary care physician. If you have patients who are who have questionable document status that doesn't impact their ability to get a physician, I have been very happy to provide care to folks who sometimes need surgeries and have no insurance, and that's a huge barrier. But our local hospital systems, the Brown University, formerly Lifespan, as well as Care New England Women and Infants, have charity care programs for folks that need surgeries. And so it's one of my great pleasures in life to tell people who kind of have this scared look on their face and are afraid to tell you what their background situation is, that you need surgery and we're able to provide that to you. So I think that's something that not a lot of people know about. And especially in the climate that we're in now, I'm finding that folks who are being screened with these questions that Dr. Hausberg was talking about, Dr. Cole-White, that we ask them consistently about their risks for anxiety, depression, their ability to pay, their fear about paying their rent and making, being able to pay for diapers and things like that. They're often telling the screeners that everything's fine, nothing's wrong here. And that's a really common experience, especially for immigrants and especially in this climate. Even folks that are here legally and documented, it's just a very scary time for everybody. So they will often tell the screener everything's fine, but then when I get into the room, they are sometimes a little more forthcoming. And it's really a great pleasure to be able to tell those folks, we have help for you. So thank you for telling us. We're going to actually meet you halfway. We're not going to just listen to your problems and then say, sorry. We actually have something for that. So
Dr. Domozgowski, so how does a gynecologist contribute to a woman's preventive health once childbearing is complete?
Thank you, Albert. First, I just want to start by saying thank you to both you, Michelle, and Bridget for organizing this. And I think this is such an important step that we're taking. And a shout out to the American Heart Association for recognizing that one of the major healthcare crises in the country right now is more maternal morbidity and mortality, um, especially in diverse populations. I've been privileged to be a board member of the American Heart Association for the last couple of years and have been fortunate to be able to help with education in this area. So I just wanted to give that shout out before I answer my questions. But I think as a gynecologist, we get to know the patient very well. Mostly during her pregnancy, that's a lot of times how our relationship with a patient begins. And then after they have their children, they continue to see us for their yearly exams. We get to know them very well, and that's part of what I think draws us to being OBGYNs, kind of the intimate relationship that we have with our patients, and the fact that we know them very well, we know their family, and we often become their confidant. Sometimes, especially with younger women, they don't have a primary care physician, especially in the state of Rhode Island with our healthcare shortage, especially for primary care physicians. And so our role becomes not only doing, pelvic care, reproductive care, but also well women health screening to make sure that women are getting screened for breast cancer. They're getting screened for the things that they may have been at risk for in the previous pregnancies, like diabetes and hypertension. And although we can't, as specialists, OB/GYN specialists, we can't necessarily treat these conditions, we can make sure that the patient gets referred and gets the correct treatment through these referrals. So that's how we actually help once childbearing is completed.
What I'd like to do now is maybe, kind of focus these questions to any one of you. And let's hone in a little more specific to Rhode Island. So, what interventions that are specific to Rhode Island that are happening, and if anyone could share those. And I'm thinking like doula support, or if there's a hypertension equity program, things of that nature that you could share with the audience.
I can start if that's okay,
Sure.
since I've been involved in a couple of these programs. So yeah, Albert, you actually brought up two of the really important ones, kind of at our local community level. Doula support, we're really lucky in Rhode Island. I came from a state where this was not the case, but we're really lucky in Rhode Island that doula support is actually covered by insurance here. And so we have, just sort of a huge network of independent doulas that are kind of based within the community that can provide support to pregnant and postpartum people. And I call out that postpartum piece because I think that we often think about doulas as being sort of labor support people, right? That they're there in the delivery room. But actually, there's a huge benefit to having doula support in the postpartum period too. So I would say, one of the things that we're doing is kind of working on developing those partnerships to be able to provide doula support to kind of anybody that needs it. I'm involved in a program back where I came from in Pittsburgh, where we're actually partnered with a community organization, and we provide doula support, but we've also kind of done some additional training for our doulas that they have kind of additional expertise in high blood pressure and pregnancy. And so they can not just provide kind of that wraparound care and support that they would in the postpartum period, but also are sort of directly connected with the healthcare team, such that, when we talked about that postpartum period being this really high risk time for high blood pressure, those doulas can actually almost be sort of an extension of our care team within that partnership. And so I think that's a model that we would love to bring to Rhode Island as well, and have started to work on building those relationships. I mentioned the hypertension equity program. That's a program that all of the people who deliver at Women and Infants have access to. And this again is for people that have high blood pressure and pregnancy. That program also, kind of one of the integral members of the care team in that program is our community health worker, who, just as kind of Libby brought up, all of the other kind of social determinants that contribute to our patients' health in the postpartum period. Our community health workers have been really integral in helping us address not just the hypertension, but also everything else, that's sort of going on in people's lives in that period. And then I'll stop talking, but I just want to bring out one more quick shout out, is that kind of on the advocacy level within the state, we've been working on getting the state to cover blood pressure cuffs and education for pregnant and postpartum people. And so that is a bill that was heard in the Senate about a month ago. And then just last week was heard at the House Finance Committee that I went to testify about kind of the importance of that. And I bring that up, I think we've talked a lot about this kind of the importance of this monitoring, not just in pregnancy, not just in the immediate postpartum period, but longer term, right? If you can give somebody a blood pressure cuff during pregnancy, teach them how to use it, teach them what numbers are concerning, that has implications for their health way beyond pregnancy or the immediate postpartum period, and has implications for the health of their whole family, right? In addition to kind of all of these amazing health benefits, we have lots of data to also suggest that this is cost effective, right? This actually could save our state money by giving people access to these types of devices and this education. So we're hopeful that it will, that it will make it through. I'm happy to put the link in the chat too, if people want to also submit testimony or, just kind of submit support on behalf of these bills.
Thanks, Elise. And then also there's a lot of work happening from the Rhode Island Department of Health. They're working currently to amplify the Hear Her campaign, which is out of the CDC. You might have seen information about the Hear Her campaign. And that's really about focusing on listening to birthing people, women, families, postpartum, especially listening to any sort of complaints that they might have. And then also to really sort of help families and birthing people understand that sort of what we call the urgent maternal warning signs, or things that could happen during pregnancy or postpartum that are really reasons to contact your doctor. And so a lot of the time people will have symptoms but don't think they're significant, or don't reach out, or they reach out to a health provider that might not see that as sort of an urgent warning sign postpartum. So really focusing on listening to families, listening to birthing people, and getting people the support they need postpartum. So there's a lot of great resources that if you have a health office, you can request to have hanging up on your wall with the urgent maternal warning signs. There's hands out for patients in multiple languages, magnets, and things like that. And then through the what we call the PPDRC, which is the Pregnancy Postpartum Death Review Committee. This year we've been reviewing deaths in Rhode Island for 5 years now. And this year we are actually trying to go to meetings at each of the birthing hospitals to talk about the findings of the PPDRC and what this means for our communities, and what community people who work at that hospital should be doing in pregnancy and postpartum to help support families in Rhode Island.
Wow, there's wonderful work that's being done in Rhode Island around this issue, which is so vitally important. And so I'm going to go back a little and really talk about, or get some insight as to, as women age, what is the role of the gynecologist, in primary care as women age. We've been talking a lot about, maternal and postpartum and prepartum, but what happens, as a woman ages? And I'll open this up to Dr. Domagalski.
Yes. So thank you, Albert. I think as a woman ages, or as anybody ages, as a matter of fact, the likelihood of developing diabetes and hypertension do increase. And so we know that even if a woman did not or a patient did not develop those during pregnancy, they still are more at risk of those things as they age. Family history also plays a huge role in that as well. And so again, sometimes patients see us more routinely than they do their primary care physicians, whether they have one or have been able to establish care with one. And so every time we see a patient, we're taking their blood pressure. Every time we see a patient, we're asking them what type of healthcare screening that they've had done. So we often will do screenings like, besides blood pressure, for diabetes, for cholesterol, for thyroid conditions, again, especially if they don't have a primary care physician. And although we can't treat those conditions, we can try to intervene with our colleagues in terms of primary care physicians that we may work with to try to get those patients seen and treated. In menopause, people do have more risk of these things as well. We talk to them about hormone replacement therapy and how those may or may not help them, how they may or may not be beneficial to both their well-being and for potentially not really preventing cardiovascular disease, but actually helping potentially with cardiovascular health.
So I guess, another question I would have, and this would be for Dr. Hausberg. Um, we talked a little bit about, as a woman ages, but what impact? Let's hone in a little more on hypertension. So what impact does hypertension have in pregnancy, long term, on for long term outcomes for women? So I'm saying, if we think about hypertension in pregnancy, what is the long term impact of that?
Yeah. Yeah, and I think we talked a bit about that before, but just to kind of go into more detail, we know that people that develop high blood pressure in pregnancy have a much higher risk of, like we talked about, developing long-term chronic hypertension, a higher risk of things like stroke, heart failure later on in life. And, I think the teaching historically had been like that risk is happening, when people are hitting menopause, right? That risk is happening much later on in life when people are in their, in their 50s. But really what we're seeing, like now that people are actually kind of paying attention to this and paying attention to the fact that pregnancy really is a stress test for long-term health, is that risk is actually happening much sooner than we previously thought it was, like really within the first couple of years after pregnancy. And I think what's really exciting to me as a researcher and as someone that really feels committed to improving the kind of life course trajectory after pregnancy is that we may have an opportunity to actually intervene, right? So all these things that we're talking about, making sure we're following people's blood pressures, using other, kind of having other resources like doula support or other interventions kind of in the postpartum period may actually reduce the risk that somebody develops heart disease or cardiovascular disease long term. And then the other really potentially exciting thing is like whenever we talk about a pregnancy, and the postpartum period, I sort of see the postpartum period too, especially for people that want to have more pregnancies, as kind of the preconception period for another pregnancy, right? And so if we can improve how we treat people, if we can improve that trajectory of blood pressure in the postpartum period, we may actually not just improve people's long-term health, but we may actually improve outcomes in a future pregnancy. I'm going to put in one more plug for things that we're doing locally. We just recently launched kind of a multidisciplinary high blood pressure postpartum clinic. So it's a clinic that is kind of run jointly by maternal fetal medicine, cardiology, and obstetric medicine, with really the goals of kind of exactly what we're talking about, trying to bridge these gaps in care in the postpartum period. We know, as everybody's kind of mentioned, we have a primary care physician crisis in Rhode Island. And so what we're finding is like, we may be doing a really great job with some of these programs treating people in the immediate postpartum period, but beyond that, people may not have a primary care doctor. They may not have someone they can follow up with. And if they're still on multiple blood pressure medicines, if their blood pressure hasn't kind of come back to normal after pregnancy, what we're finding is that like their prescriptions may run out. They may not have somebody that feels comfortable prescribing them medications, or they may not have somebody that can actually take care of that high blood pressure. And so we've sort of designed this clinic and kind of ongoing follow-up to basically be a bridge to get people connected with primary care and make sure that we're, continuing to treat people beyond that kind of immediate postpartum period.
So Dr. Flores, I'm going to ask you, what are some of the challenges, for patients that are maybe lacking legal protections?
I mean, so many. We've unfortunately had a pregnant patient detained and awaiting deportation in Louisiana among our own population. There have been reports with video available of ICE showing up at Rhode Island Hospital, unclear whether they're looking for patients or professionals. I say often that if the goal is to detain and deport immigrants in Rhode Island, I'm not sure where our labor force is going to go for healthcare, because we're a state and a country made up of immigrants. So what are the resources? There are some excellent resources that I can put in the chat. I'm going to shout out a good friend of mine, Dr. Elise Trin, another federally qualified health center doc, who's very involved in educating folks about what their rights are regarding when ICE shows up. For the patients themselves, we try to educate them that, nobody can enter your home without permission, that nobody can ask you for paperwork unless you allow them entry into your place of business or place of work. But unfortunately, it seems as if we're in an environment where norms and rules don't necessarily apply.
So, I think this has been a pretty robust conversation. But, there are so many aspects of all of this. We're seeing some social determinants of health, that contribute to women in maternal health and the issues that they have to confront, and some of the challenges that many are confronting today. So I just want to thank you, for this robust conversation. And I'm always hopeful, and the hope is that we can continue this work, and really have some positive outcomes in the long run. So I just want to take this time to thank our panelists, our supported, with Dr. McCabe, and just thank you for attending this. And I hope it was proved to be fruitful. There are a few things I would like to share. We are offering CME credits. And there is actually a website that you will need to go to and actually sign up. And once you sign up, you will have access to the video, which is about a 1-hour video that you will watch, and so you can actually scan on this QR code here, and that will take you to the website where you would be able to do that. The title of it is The Role of Maternal Health in Hypertension. And so, definitely I would encourage anyone who is looking for CME or wants to delve in a little bit deeper into, cardiac health and maternal health. This would definitely be a great resource and, a great opportunity for that. On behalf of the American Heart Association, I want to thank everyone for attending today. And as I said, I hope that this was fruitful and, proved to be, something that some takeaways that you'll have, as we continue this work. And, a side note, we're in this together. And when we can really pool our resources and our expertise to address these issues, I think that there's more power in those numbers. So thank you. Thank you all. And thank you, my panelists. Forthcoming, I would say by tomorrow, we will be sending a brief survey out for our participants to share with us, what they thought of this. This is really going to help us as we continue this work. And if we decide to do this again, if there's another opportunity to, have a conversation similar to this, we'll know what we learned and what needs improvement. So I would definitely encourage you to take that survey so that we can, review that and really make this even better. So once again, thank you all so much, and have a great day.